I'm Dr. Lucia Voschel. I am the nurse ethicist for IU Health, and I'm also the adjunct assistant professor in the IU Health School of Nursing. So I want to let you all know that this lecture is being tape recorded and broadcast. I want to welcome our colleagues at IU Health North, IU Health Arnett, and IU Health Ball Memorial Hospital. Thank you for joining us today. The conflict of interest disclosures have all been collected from today's speaker, and there are no relevant financial conflicts of interest to declare. So here we go. This is the fun part. Which button do we push to move forward? All right. So it is my honor and privilege to welcome you to the inaugural K. Woltman K. Woltman Foundation. Let's try this again. Timeout. So I learned this from Improv. If it didn't work right the first time, do it again. So, hi again. It is my honor and privilege to welcome you to the inaugural K. Woltman Endowed Visiting Lectureship. This lectureship was made possible through a remarkably generous gift from the Woltman family to the Indiana University School of Nursing. The K. Woltman Endowed Visiting Lectureship in Health Communications through the IU School of Nursing is an annual lectureship that will allow students, trainees, clinicians, community providers, and faculty access to nationally recognized experts focusing specifically on the critical issues of communication across the lifespan. Mr. Richard Woltman is an IU graduate from 1952, the Kelley Business School, and the family wanted to do something positive in memory of K. Woltman. And so what they came up with was this visiting lectureship. This is K. Woltman. Mrs. Woltman was a philanthropist and volunteer leader in several healthcare, education, and community service institutions and organizations. She served on 5 boards, including Scripps Health, San Diego Hospice, University of San Diego, Rotary Club of La Jolla, and Boys and Girls Club, concurrently while still holding an active role in the Woltman family business. Kay did not see a world with a glass ceiling. She believed that hard work and preparation enabled her to be competitive. Mrs. Woltman was a director, executive vice president, and chief operating officer. She was a superb businesswoman and was guided by high values, great dignity, grace, humility, and wisdom with high energy. These were the hallmarks of her work. Kay died on August 27, 2010, after a courageous battle with cancer. The family describes care as wonderfully compassionate, but it was obvious from them that the team caring for her was ill-equipped to deal with all of their questions. Some care providers weren't completely prepared to have conversations about end-of-life care, and Mr. Woltman and his family really didn't know what to ask. This lectureship is part of a 3-part initiative to develop and implement best practice models for enhanced communication among patients, families, and providers who find themselves in end-of-life situations. I have the honor of serving as the project director for the second part of the initiative, the Woltman Interprofessional Communication Scholars Program, or WISP. The WISP will provide training to healthcare providers to implement evidence-based practice that improves patient and family satisfaction in end-of-life care. The IU Health System serves as our primary clinical partner for the WISP program. With the participation, I hope we have a few WISP participants, WISP scholars in the audience. Could you please stand up or wave and be recognized? I need to also tell you, thank you. I need to tell you that this lecture was rescheduled. How many of you remember our snowstorm in February? We had hoped to have this lecture on that date, so we are grateful that our speaker was able to change, and our WISP scholars were prepared to come in February, and so August has been a challenge for us. So we are very grateful to the Woltman family for their tremendous gift. Today, I also wish to acknowledge our partner in hosting the lecture. I am a very proud faculty member of the Fairbanks Center for Medical Ethics and grateful for their support and collaboration in hosting this inaugural K. Woltman lecture. So I am especially grateful to Amy Chamness, the program coordinator at the Fairbanks Center, for assistance in making my slides look really good and keeping me on track with all the announcements that I am required to make. So with all of that introduction, I would now like to welcome our speaker. Katie Watson is an assistant professor in the Medical Humanities and Bioethics Program at Northwestern University at the Feinberg School of Medicine. She is a member of the Ethics Committee of Northwestern Memorial Hospital. She is the founding editor of the Medical Humanities publication Atrium, which is she's an award-winning teacher of bioethics, humanities, and law to medical students and master's students. Professor Watson graduated from the New York University School of Law in 1992, and after years as a public interest lawyer, she completed fellowships in clinical medical ethics at the University of Chicago Medical School's MacLean Center and Medical Humanities at Northwestern. Professor Watson also has a background in theater. She is currently an adjunct faculty member at the Training Center of Chicago's renowned Second City Theater. And in 2002, she created what appears to be the country's first medical school improv seminar designed to teach communication skills, a unique interdisciplinary adaptation she calls medical improv. Professor Watson's lecture today is titled Practicing for Practice, Medical Improv, Ethics, and Advanced Communication Skills. Please join me in welcoming Professor Katie Watson.
Thank you. Hi. Physician Danielle Offrey shared this story in the New York Times. It was the morning of Julia's discharge from the hospital. She asked the same question about every bottle. Will this medicine make my heart better? I squirmed painfully around the question, weaving ever more elaborate explanations about controlling symptoms. I could not bring myself to tell this young mother that she was going to die. As a result, Dr. Offrey tells us, this patient walked out of the hospital without full knowledge of her prognosis. Dr. Offrey explains that she was fully aware that her job was to have an open and honest communication with her patient in a patient-centered manner, and that when she didn't do so that day, she knew at the time she'd been derelict in her duty as a physician. So let's think about that for a moment. Why did that happen to this experienced clinician? The important thing that Dr. Offrey is telling us here is that she didn't lack information about ethical obligations or communication imperatives at the end of life. What she's telling us is she didn't do them. And perhaps even more startling, she goes on to explain she wasn't the only one. Everyone responsible for this patient's care, intern, resident, attending, cardiology fellow, cardiology attending, independently fell short of the Charter on Medical Professionalism. As she puts it, not one of us could say those words to her face. I think Dr. Offrey's wonderfully candid story illustrates something very important about practice, putting what we know into action. And this is the first definition of the word practice. And that's just the very familiar distinction between the practice of medicine and the study of medicine, right? Reading about surgery doesn't make anyone qualified to cut me open. And that's because there's a big difference between knowing what to do, Dr. Offrey's content knowledge about ethics and end-of-life care, and moving those lessons into our muscles to actually put them into action. Cognitive understanding plus physical action equals practice, right? In the practice of medicine and many other things. And that's true in all of clinical medicine. And I use that term to mean nursing, doctoring, social work, physical therapy, et cetera, et cetera, et cetera. And it's also true in clinical ethics, which is the practice of applying bioethics knowledge to the action of case consults at the bedside. So let me share with you, this is the Professional Association for Medical Ethics Consultants puts out this book. These are the core competencies that we all have to have. And like any other clinician, this group has broken out the competencies into knowledge and into skills, right? And here's a table that I know you can't read, but I just want you to get the gestalt here, this is just the skills category. There's another page of content knowledge that ethics consultants must have. And about half of these 16 skills that they require ethics consultants to have, I would call communication or interpersonal skills. So here they are broken out. Take a look at this list. I think if we tweaked the wording, this would actually be a good list for all healthcare professionals. And of course, the ACGME and other professional and discipline-specific groups have their own lists that look fairly similar. There's variations on these themes. The Ethics Consultant's Core Competencies book says that these attributes, attitudes, and behaviors can be nurtured and should be taught. which is terrific, right? You don't have to be born with this. It means we can teach and learn this. Way to go. Then I turn the page in this book to find out how we teach these advanced communication skills, and the report ends. There's no other page, right? That's it. They don't tell you how to teach these things. They just say that we can. Well, great. So we have lots of standards that say we can and should and must teach these things, and not as many methods for teaching these interpersonal kind of communication skills. So this brings us to the second meaning of the word practice, the thing we need in order to get good at actually doing something. Right? But it's hard to know how in this realm. So in today's talk, I'm going to focus on both meanings of the word practice. The practice of ethical clinical medicine, the way in which we put our knowledge of ethics and medicine into action on behalf of patients, and how we might practice doing that to become the most excellent we can be in it. Before I launch into the heart of my talk, I have to make a confession. When I hear these words, my brain, the first thing my brain does is convert it to this. Okay, I'm kind of allergic to communication trainings and these kind of things. They're really hard to teach, and so we go when we try. So I'll leave it at that. I want to say, and my husband's in the corporate world, and that's what he and his colleagues call a lot of the touchy-feely trainings that they're required to go to. So I've adopted or inherited the term. I just want to say that my work in law and bioethics makes me too busy for advanced patty cake, and since you're in the business of saving lives, I'm going to assume that you don't have time for it either. Instead, I'm going to attempt to answer this question of how we might teach communication skills that are required for excellent and ethical medical care by introducing you to what I think is a promising new method that I call medical improv. And medical improv starts with regular improv. Please raise your hand if you've ever seen improvisational theater. Raise them high for me so I get a sense. Everyone's seen Whose Line It Is Anyway or some theater, almost everyone. So most of you in the room, it sounds like you know that improvisational theater is theater that happens without a script. It's made up on the spot by the actors in the scene. And it's not synonymous with comedy. We often associate it with comedy because that's often what we see, improv comedy. But I'd like you to think of it like a movie. Just as a movie can be a comedy, or it can be a drama or a romance or a thriller, improvisation is a genre of theater. What defines it, when we're looking at comedy, humor is what defines it. When we look at improv, what defines it is spontaneity and honesty, right? This collaborative creation that we do. So even when you're not trying to be funny, however, because it is spontaneous and it is honest and mistakes will be made, it is often very fun. So even when the goal isn't comedy, it can often be something that naturally leads to humor, which is why I call this training method serious play. So here's how I came to this. In 2001, I was a lawyer and bioethicist who taught at a medical school. I am still those things. And spent my free nights and weekends studying and performing improv. And I thought of that as just two completely separate worlds, unrelated, until my boss started showing up at my improv shows. Think about that for a minute. Imagine having a nightmare where you're on stage and you don't have a script and your program chair is in the audience. And just understand that that was my Saturday night, like in consecutive weeks. The good news is it turned out that she was just a theater fan, that I was not going to lose my job. And the happy accident was she was working on a book for Oxford about the epistemology of medicine. How do doctors know the things they know, and how do they know what they don't know, right? This is about cognition, sort of philosophy of medicine. And so she was just fascinated as a theater fan and someone who was thinking about cognitive processes to ask me, how do you do that? How do you make it look like you have a script, but you have no idea what's going to happen? You haven't pre-planned any of this. And it required me to, articulate and explain to an outsider how it is improvisers did what they did, but also to think about her work and think about how doctors do what they do and to see the overlap in that. So that's how medical improv was born. So let me tell you a little bit of what I told her. The simple answer to the question of how actors can look like what they're doing is scripted starts with the first simple rule of improv, which is the rule or the concept of yes and. And I think Malcolm Gladwell actually summarized something in a lovely way that actually applies to, well-trained people in an emergency room, as well as improvisers on stage who don't know what's going to happen next exactly. I've put this image of a blueprint here because I think of a blueprint as a script, right? If I come in with a script in my head, here's how I think it's going to come. Lucia does not live in my head, and that's not going to be a successful interaction, right? Instead, there's this principle of yes and, which means you affirm your scene partner's reality, whatever they bring, and you also add something constructive. And you go back and forth in that way. And when it's done in a collaborative way, I think of every sentence as a brick. Lucia and I will build something together. It will be interesting, but neither of us know what it will be until we get to the end of it, right? And that's a very different approach. Scene partners without a script have to quickly lock into relationship and collaboratively develop a shared story and shared outcomes, right? And what we build together might surprise us both. So I want to ask you to apply this simple lesson to an interaction that I observed between a physician, a patient, and a family caregiver, okay? So in this scenario, 2 or 3 weeks earlier, this patient was diagnosed with advanced esophageal cancer. He was told he had months or years to live. And he agreed to a 10-day trial of palliative chemotherapy and radiation to see if his tumor could be shrunk. And this interaction I'm going to show you happened in the middle of that 10-day treatment. So just read this for a moment. I hear some chuckles. So in the first step of this, I want to invite you to rewrite the radiologist's lines using the principle of yes and. So same first line. Let's just break it in two. How could you say, or how could this radiologist first say yes to the daughter caregiver? How could this radiologist affirm the daughter's statement or the daughter's feelings? Can I just have a suggestion of a phrase or more than one suggestion? What would be a yes statement? I'm sorry to hear that. Here, can you add one more phrase? Hear what?
Hear that your father's not feeling well.
Okay, so that affirms. You said your father's not feeling well, and I will affirm your father is not feeling well, and I'm sorry to hear that, right? Yes, I'm sorry to hear that. What's another way to phrase it? There's 100 ways to skin this cat. Let's hear one or two more. What's another thing you could yes?
What are your worries?
That's a question. Great. What are your worries? Can you rephrase that to a statement?
Many families have worries about being in this type of situation.
Terrific. So you're picking up on the word worried. You're really worried about your dad. Tell me more, right? The idea of tell me what those worries are. But there's the affirmation of you're worried about your dad. It's just a simple yes. You're worried about your dad. Terrific. Anyone else see a yes in there? Yeah.
What about yes? I see it's still in our here. He's home, and I'm so glad you're here today.
Terrific. And you're adding the and. So let's move on to that and portion. Yes, I'm sorry to hear he's feeling bad, and I'm glad you're here today. So let's move to the and section. We can affirm the worry. We can affirm the physical state of he is feeling bad. We don't have to deny that. What would be an and statement? So we've said yes, we've affirmed the daughter's reality. Her father feels bad and she's worried. What would be something you could add that would be constructive? And? You must have a lot of questions. Terrific. What's another and statement? And I'm worried about him too. Great. We're on the same team. I'm worried too. Let's talk about that. What's next? What's another and statement?
Tell me more about what he's been experiencing.
Tell me more. And I'd love to know more about what's going on. Great. There's 100 ways to do this, right? Yes, these treatments are tough. They can really take a toll. Yes, you're worried about your dad. We can yes all sorts of things in here. And the and they're worth getting through because sometimes they really help, right? If we're going to talk about treatments. And his response is normal, so you don't need to worry about that, though I would like to help you with the symptoms, right? But your bigger worries. Pick what to yes, pick what to and, right? To affirm that. Now, the second thing I want to ask you is who cares? Right? Why does it matter? What was wrong with this one? Why would we bother to try to revise that?
Totally negates her what she says. It's a disagreement that the patient's miserable, and it kind of discounts her worries.
Yeah, in improv, we'd call that a denial. She brought the one brick of a one reality, and that brick was taken away rather than added to and affirmed, right? So it could make her feel negated. The translation is you're wrong. One of us is disconnected from reality. It's the sort of, you're not hungry, people are starving in China. Those both could be true, right? It's not impossible. So why would the radiologist say this the way she did? She's an incredibly intelligent, kind, well-intentioned person. Why would she phrase it that way? What's going on for her? What might be a reason?
Fear.
Fear of what?
Fear of having to address the hard facts.
What are the hard facts?
Well, he's got cancer, and he's probably not going to make it too much longer, and the radiologist doesn't want to have that conversation.
So it keeps it real short, real light. Anything else? Any other barriers to why this wonderful radiologist might have this hallway exchange? Busy. It would be much more time consuming to affirm and see if there's any other symptom palliation we could do. It would take a lot more time of emotional energy if there's nothing else to be done to just be like, this is how it's going to be. How are we going to handle that?
She's avoiding the emotion.
She's avoiding the emotion. And so there's another personal reason behind that I think is really interesting and rarely noted. She would have to acknowledge what she's doing is hurting him. And I think this is so ironic that you all went into medicine to help people, and in order to help them, you have to hurt them. In the short term, treatments can be physically painful. You have to be the messenger of psychologically or emotionally painful news, right? And so I would think that would be hard to own and say, yeah, I'm hurting you right now. And the reason you agreed to this and wanted this, have you changed your mind? Should we talk, right? I think that's hard. This got her out of this much faster. And the exchange on this slide was obviously improvised. No one knew what they were going to say that day. We don't wake up with scripts in our hands. But I typed it like a script to make a point about what I've come to think of as the movie of your life. From a narrative perspective, the question we'd be asking is, who's the protagonist in this scene? In the movie of the radiologist's life, this scene isn't included. It's on the cutting room floor. She's cared for thousands of people. I bet she's had hundreds of these hallway exchanges. I bet you $1 million she doesn't remember this moment at all. The problem is that what's routine for the caregiver is of unparalleled intensity for families and patients. So in the movie of their lives, this may be the pivotal scene in a life story. The illness experience may be pivotal scenes in their life stories when they are the protagonist of that movie. And I know this firsthand because I will share with you that I was the daughter pushing the wheelchair in this exchange. And as a concerned caregiver, it is insane how 2 years later, how vivid my memory is of this cheery little sentence feeling like a slap in the face. Hilariously, at the exact same moment that this happened, the medical improv and professor part of my brain just thought, that's unnecessary. Just affirm and add. Yes, and what's the problem? This is so easy. So it struck me in two ways in that moment, because my reality that my dad was literally having the worst day of his life because he was almost asymptomatic before he had a cough, and that's what led him to be diagnosed with this insanely advanced cancer. It was the treatment that made him tank. So he was literally having, I think it's fair to say, the worst day of his life that day. So that was my reality. Her reality that this treatment reaction is normal is also true. Those are both true. And the yes and approach would allow us to embrace both those realities. So when we discuss end-of-life treatment and ethics, we often focus on those neon light moments of diagnosis, prognosis, big decisions, advanced decision-making. And of course, those are critical. But I bring you this hallway moment to emphasize that the advanced communication skills taught in medical improv also are intended to make us attentive to the everyday fabric of care. Interactions that build trust and actually do make those big conversations easier. So that's the principle and an illustration of yes and, which is a foundation of improvisation. So let me show you some other lessons that improvisers have to learn. And if you're a clinician, this list might resonate with you too, because I think that improvisational theater skills have a surprising and substantial overlap with skills needed for the practice of clinical medicine. Medical professionals need exceptional communicative, cognitive, and interpersonal skills in order to improvise appropriate responses to unpredictable situations and a wide range of individuals. And because improv is a genre of performance art grounded in principles of spontaneity, adaptability, collaboration, and skilled listening, and because they have a training system for it, I ask you, why reinvent the wheel if you can repurpose it? What turns improv into medical improv, so let's shift gears from just plain old improvisational theater to medical improv, is the careful selection and adaptation of improvisational theater principles and exercises to match medical goals and skills, okay? And then that's followed by targeted discussion that ties those skill sets to the practice of, to the medical environment, whether it's physicians, nurses, social workers, fill in the blank. I use that term broadly. So here's how it developed. Northwestern students are required to take a 10-hour medical humanities seminar, both in their first and second year. And they have a list of about 15 they can choose from, but they must rank them and choose one. And we think of this as cross-training, strengthening different muscles that contribute to the same goal, or stimulating those same muscles in a new way just to get out of a rut, learn something new in a new way, right? So in 2002, I created a 10-hour medical improv seminar, put it on the list, and after every class, I asked the students to anonymously evaluate their experience. And I felt like Auntie Mame. I was sure they were going to think this was insane, that we'd do it once and it would just be crazy and they just wouldn't buy it. Shockingly, they seemed to love it. So in 2011, and every year I'd be like, this is the year. Those were the aberrations. These ones are going to tell me this is stupid. And in 2011, I had 8 years of data, and I thought, well, I will go ahead and publish this. So I published this in Academic Medicine, and I'll show you. The earlier slide was from that same article. Here's some of those results. And those of you in medical education know that it is very unusual to have numbers this high from angry medical students. An article I cited in that, a pharmacy school later used 10 or 12 hours of improv training in their communications course for pharmacy students, and compared standardized patient test outcomes before and after they introduced this, and saw a significant improvement in test scores even among students who didn't enjoy the method, which is interesting to me. This year I had IRB approval to do a self-assessment before and after the course, skills assessment, and the students, it's unpublished, but the biostatistician tells me very significant change over time of student self-assessment, and next year I hope to have funding to do it in a randomized way with standardized patients. So the data in this area is very new and thin to start with. But the article in Academic Medicine, I thought, that's it. I'm done. I published this, whatever. We'll keep doing it. Got an amazing response. I've never gotten more calls or emails on anything I've ever published. It turns out that people are hungry for these kind of training methods, and they would call me and say, can you send me your syllabus? And I'd say, have you ever done or taught improv? And they'd say, no, I'll just read what you wrote and teach it. And I thought, boy, that's not going to go well for you. So I thought I needed to, so I felt badly saying no, but it's odd that I teach at Second City and at a medical school. I get that that's weird. So I decided I should put my time where my mouth was, and I held a train the trainer workshop to teach people how to do this. And I thought maybe 3 people will come. 18 people waiting list, shocked me, including Lucia, and then did it again another year, thought, okay, well, that was it. And then same thing, 18 people waiting list. So we're doing it again in Chicago in June. And now I've moved from medical students to developing applications for experienced clinicians. All right, so up on the training scale. So let's look at why I think that might be useful. And I should share with you, so I made a website because I got a lot of emails, and I can refer people to this. This has free downloads of almost everything published in this area. And gives you a little more information about it for those of you who are interested. So here are the 3 domains in which improvisation, I think, work. And it's interesting, this iterative process, how this experiment will work has made me have to think about something that I just do and don't think of this way. This is not how improvisers talk. All right, this is how academics talk. So communication. When we think about communication, we think about something that's of course includes words, but it's not just words. So let's return to Dr. Ofri's story that I opened with, where she didn't share the prognosis. Why didn't she? And you guys have suggested the role of emotion, and she speculates on that too. She says, it could be that I over-identified with my patient, or I let my emotions get the better of me, or that I was an out-and-out wimp. No doubt all played some role. But why did it take us so long to tell her? And she makes this suggestion. So in medical improv, we do exercises that help clinicians recognize their own emotion in the moment and articulate them and act on them appropriately when that's helpful for patient care, or recognize when they are barriers to patient care. And we drill skills like deep listening, collaborative story building, emotional recognition, and empathy. So when we say communication, we're talking about something in addition to just saying the right phrase, right? On the flip side, let's think about emotion, the other side of that communication dyad. How does or should patient emotion affect clinician communication? All right. So in this instance, shortly after I published that article in Academic Medicine, a neonatologist on the East Coast called me, and because he directs a fellowship program, and his fellows had just finished an assessment with standardized patients, all right? And the scenario was that sort of scenario that's so difficult in the gray zone where someone goes into premature labor and they have to make an awful decision about whether to consent to life-sustaining care or to offer informed refusal of that care and let the baby die peacefully, right? And they weren't expecting to go into labor, and they have a tough decision to make in a period of hours, all right? And so their ability to give informed consent or informed refusal is based on learning some information in a fairly rapid amount of time. They have some hours, but this was a surprise to them. So there's a lot going on for them here. When the neonatology fellows simulated this encounter with standardized patient, their physician faculty gave them high grades because they all knew all the relevant data. They presented it accurately. They covered everything they needed to cover about the statistics and outcome possibilities and probabilities. On paper, that means they accomplished the ethics goal, right, of delivering the information that a patient needed for informed consent or informed refusal. However, many of them got failing grades from the standardized patients. Here's some of the things the standardized patients said. So it's interesting to think, what were the fellows doing? They certainly weren't saying words that communicated this. What were they doing that made the standardized patients feel this way? He shared one video with me where the standardized patient is literally crying and pushing her chair back into the wall like she wants to disappear. And the fellow is like a freight train with this data script, right? And which is crazy because I met these fellows and they're just terrific people. They're incredibly lovely, kind, well-intentioned people. So what could be going on there? I think that their excellent residency and fellowship training had led them to acquisition of tremendous clinical knowledge, and it had outpaced their communication training. Right? They weren't able to put what they knew into practice to actually get true informed consent or refusal and a positive patient interaction. They hadn't had the training to do that yet. So I worked with them and with medical improv exercises about empathy and nonverbal communication. But actually what I was teaching them is what I've come to call going off script. Right? I think that whether it's younger clinicians or more challenging environments, we fall back on our scripts. And this advanced skill is shifting tone, emotion, and pace or language just to meet someone where they are so that what you need to communicate is actually received, right? So patients are obviously going to find individually tailored exchanges more rewarding, but I want you to be very clear that perceiving and responding to nonverbal cues is not just a matter of being nice or being sensitive or touchy-feely. The medical goal of going off script is to maximize what they get so you actually have practiced good medicine. It's not about being nice. It's about being an excellent clinician, right? Also, in medical improv, we think about teamwork. I mean, all these things are going on at the same time. But let's think about who's on the team. Louise Aronson published a wonderful essay just last year that looks at this concept of team, in my opinion. Her father was admitted to the hospital, and she was concerned about his falling blood pressure. And she was wanting to be helpful. She had said that his blood pressure was dropping. They were giving him fluids. They thought it was fine, and they turned off the monitor, right? So she's seeing the monitor go back on, but now it's not making noise. And so she has gone to the nurse's station a couple times to say, the monitor, and they're adjusting his fluids, and they're saying he looks fine, this is going to be fine. And so she is worried for about 2 hours. The difference here is she's also a physician. So after about 2 hours of, as she puts it, quieting her internal alarm, she says to her father, "Dad, how much would you mind if I gave you a rectal?" And he says, "Do what you got to do, kid," because he too is a doctor. So she finds a glove and some lube and walks out to the nurse's station with a bloody hand, and it turns out he is having a massive internal bleed, right? And his life is saved. But what's interesting as she reflects on this event is she says, "What's interesting to me is how much more comfortable I felt performing an intimate procedure like a rectal on my father than demanding the attention of the professionals assigned to care for him. Abiding by the unspoken rules of medical etiquette, I quieted my internal alarms for more than 2 hours." And here's why. Here's what she learned from it as a physician. So the question is, how can you make patients and family members part of the team? Are they on the team? Who's really on the team? And when we talk about and take a close look at teamwork in medical improv, we look at questions of status, what it feels like to be challenged, regardless of who you're being challenged by, what expertise is in whose domain, and also who's leading and who's following. We all know that in well-functioning teams, it's not always the same person. It's situation and expertise dependent. Can our teams have that flow where we can separate out? I'm leading and following at different moments. I recognize them, I know when, and I'm fine with either role, whatever's best for the patient or the family. Medical improv is also pays attention to cognition. And this point and this separation was raised for me last fall. I was asked to do a brief workshop at the 6th Annual International Conference on Diagnostic Error. Not an area I know that much about, right? But I was asked to think about whether medical improv could be useful in helping to reduce diagnostic error. And that made me think about cognition. What I thought was so fascinating about that is I know more about safety issues in the hospital, right? But if we were going to talk about safety, generally we talk about teamwork and communication and handoff and that sort of thing. But diagnostic error often, communication requires two people in the way we think about it. Diagnostic error often happens in one person's head. Right? So how do we do something different with our cognitive patterns? And what I did with them was take a classic a diagnostic error case in which a child died because of a series of missed opportunities and incorrect assessments of the situation, and identified all those moments and then found and adapted and partnered medical improv exercises that at each moment in the decision making or the thought process perhaps could have caused people to do something different. Find what's the pattern that they've fallen into and how could they maybe pop out of it, right? And again, I thought, this is about 40 physicians in their 60s, and I just thought, this isn't going to fly. And they loved it. So I'm experimenting. We're finding what it's useful for. So I want to leave you in conclusion with this very simple idea that advanced clinical skills and ethical practice of medicine require advanced communication skills. It's not optional, and it's not just to be nice and to score high on a patient satisfaction survey. It's actually required for your practice. So when we talk about practice, here are our first two definitions. Let me add two more. Could we raise what the standard of practice is for communication and ethics in medicine? Because I think your practice is too important to do otherwise. Thank you so much. I'm following very strict instructions to leave time for conversation. So if there's no conversation, I'm going to feel badly. So are there any questions or comments on this or anything that it raises? Yes, sir.
Your triad is a very useful triad, but almost all of your examples include affect or emotion. I'm curious as to why emotion or affect wouldn't be one of your core and make it a quad instead of a tri. in terms of how to think about what's important.
Yeah, I think that's a terrific point, and I think it could be that. I think there are just so many things that are subsumed, even in writing. We talk about cognition, is the way my pattern works have something to do with what it feels like to, when we talk about like premature closure and diagnosis. Am I comfortable with the ambiguity of saying, I just don't know yet, I'm going to leave that diagnosis open? There's an emotional component to that, right, of comfort with ambiguity. So I think your suggestion is a great one. I think that I'll take under advisement. I think it's for more simplicity's sake because it does go in a lot of those things.
And my experience has been that those of us in medicine will frequently, if we see affect or emotion, flee in a hurry. So you might be
I wasn't going to say that out loud, but I thank you for saying what I'm thinking. Yeah, when I say I'm going to talk to you about emotion, run, like that doesn't sound fun. These things sound like they would be in the ACGME requirements, emotion, even though we all get it, right? But again, I go back to advanced patty cake. If I say we're going to do a training that's about emotion, I personally am not showing up. So that's me. Other thoughts or questions? Yes, sir.
One of the interesting components as you got towards the end that you talked about was getting comfort with saying I don't know.
Yeah.
And I'm curious about how, when engaging your students,
Mm-hmm.
who I think would be very uncomfortable saying I don't know.
Yeah.
What have you used, what have you found in working with them about their...
It's a tremendous relief is what I found. Let me see and go back to this slide for you. Oh, I'm sorry. I'm supposed to repeat the question. So the question was, that this dealing with being in the space of I don't know must be very stressful for medical students. And what have I found or what have I experienced or how do I deal with that? Is that fair? So when back in this slide about the things improvisers have to be able to do, we have coping with ambiguity and stress, and that's part of this. My medical students are very scared of that space, but once you introduce them to them, it's very liberating. And a facile phrase I use is stage-appropriate stupid. So the point is that you're not supposed, if you know everything about medicine as a student, we're stealing your money. Go practice, right? There are things you're not supposed to know because we haven't taught them to you yet. And when we make our inquiry, we're trying to find the boundary of where your knowledge ends, so that's where our teaching can begin because we don't want to waste your time, right? So we talk about in medical improv, if you were able to get up here and interact with your colleagues and have success without a script, just think how well you'll do when you've actually studied. Right? So don't be stressed, but the idea is to raise your hand in class or when you weren't called on. The success is not necessarily having the right answer. Success is showing the professor that you're in the right place so that the teaching can begin. And so we also talk a lot about feedback. There's all sorts of side coaching. So in my article, I cite a student who talked about feeling very defensive in their clinical skills modules when the proctor or the tutor would be giving them feedback. They would just feel like, get off me, I'm doing the best I can. And experiencing the feedback process of improv without any conversation with that clinical exams teacher converted how they interpreted that feedback as being supportive and taking them to the next level versus a critique. So there is a huge frame shift that happens, but students report it's just incredibly liberating to be in a zone that says, you have everything you need, you have all the answers, you're the expert, you cannot fail. That's actually very empowering to them when they go out into that zone where they can fail, but to reframe some of it. Other comments? Yeah.
What's the relationship between medical improv and scripts? Because one of the things, I go back to the physician who did talk about dying.
Mm-hmm.
And around crucial conversations, you try to get people comfortable with some, not that you're going to have a script that you're going to use for all situations.
Right.
But beginning to practice how to say things
Mm-hmm.
without closing down prematurely yourself. I said it and then I've done my duty kind of thing.
Mm-hmm.
It seems to me it's almost some combination of learning some ways to phrase things that are difficult to say.
Mm-hmm.
Like you didn't wash your hands. How do I say that to the senior clinician?
Mm-hmm.
How do I say that? But then being also open and having all of these skills.
I think it's a terrific observation. So the question was, what's the relationship between medical improv and scripts? And the observation that it can be helpful to have memorized a sentence that kind of gets you in the door and helps you phrase something in a way, in a tough situation, though you shouldn't stop there. And I think your observation that you shouldn't stop there is part of the key, that the rest of it will be improvised. So with the neonatologist, the script was, I have to tell you these numbers and this prognostic range, and that's my script essentially. But the going off script is, can I reformat it to make sense? Because patients and families can tell when you're reading a script, and they respond, in my limited experience and what feedback I get, of like they weren't really there. Because I could tell they'd said that 1,000 times and they were just giving me the party line. So you point out the advantage of scripts, which is it can be a crutch in a tough time where you need a crutch. I have no problem with that, right? What's my opening sentence? I've said this before. The problem is when they become something that closes you off. And so I think medical improv puts people in a space where they can feel what it feels like to be not sure what happens next, or to be able to use the pronoun I more and say, I'm a little thrown by what you just said. I'm surprised about that. Tell me more. I have to, that there's a little more candor and honesty and presence than comes with a script sometimes. So I wouldn't say having that prepared sentence is wrong or bad or isn't ever useful. I'd say it's more useful when you're younger. I think the advanced clinician either has said it so many times that they've made it their own and it doesn't feel like a script, or is ready to leave that behind and just be very sincere about what's actually happening. Yes?
When you're teaching the medical improv class, about what ratio of the time are you actually doing like role plays, and are you making the scenarios, or are the students, are they in clinicals where they can bring their own stories?
Great question. So the question is, when I'm doing medical improv teaching, how often are we doing role plays, and are students able to bring clinical scenarios? And the answer is almost never. What I have found is when you ask medical students to play medical scenarios, they turn into robots. It's so weird. So we do non-medical scenarios, and again, I'll go back to my cross-training reference. Why is the marathoner doing sit-ups? It's like, well, those muscles are relevant too. So what these exercises, think of it as rehearsal in between your standardized patient and reading in the book what you're supposed to do. They break communication and interpersonal interaction skill sets into discrete parts and let you drill them. Recognize emotion, recognize it. Respond, say what you're feeling, but in non-medical scenarios, so that when we then put it together, we're in a better place. And so in the last session, one of their assignments is, and we're on our feet the whole 2 hours. There's very little talking, sitting and talking about it, right? We debrief on our feet. So in the last class, one of their assignments is to observe a clinician interaction and write how the rules of improv were or were not followed, and if they were followed, were they useful, and if they weren't. And these are people who don't know the rules of improv, right? Life just works this way sometimes. And if they weren't followed, how do you think that affected things, and do you think the rules would have contributed? So we talk about their clinical scenarios there. With advanced practitioners, we're doing more role-playing and clinical scenarios that they bring, but it's still drilling discrete sets. We're going to talk about empathy. We're working on empathy. What would be an empathic exchange? But we might still have a scenario that involves roommates rather than doctor and patient, because part of it is remember how you are as a person. And then what happens when you put on that white coat or other colored coat? How do you shift into a professional role that is distancing? And how do you show these emotions or deal with these issues as a human being first? And then let's go back into your professional role. I've found that it's been most successful to work in that way. Yes?
What is the format that you use for debriefing and feedback? Do you guys ever videotape the improv session?
No, we never have videotaped. One could, but I think if we're looking for this failure-free zone, that's a different kind of thing. The format of the debriefing, I don't have anything very fancy to say in the response to the word format. I reflect back what's happened, or I will ask the group what they saw happen, and ask the people who were up in the exercise, obviously, to go first and say, what was that like? We do some debrief, but we don't debrief every second, because there's something about momentum. And getting out of your head is a phrase improvisers use a lot. So I might see an exercise that wasn't that successful. We don't need to talk about it. We're going to do another different exercise that also works on that same set, or we're going to go back, and then we're going to debrief as we build success. Any last questions or comments? Yeah.
It sounds like this is an amazing method, and I'm just so impressed by it. As you get into the point where it sounds like you're doing some research on its impact, and I wonder if you have a sense yet of kind of how much do trainees or clinicians need? Like, how often should we be doing this? In my own experience, we get a very tiny amount.
Sure.
And so I wonder if it's enough to impact my own practice or my colleagues' practice. I wonder what your thoughts are about how much is enough of a dose?
What's the dosage is the question. The recommended daily dosage of medical improv is a great question. It's something I think about. Sometimes people invite me, extend incredibly nice invitations. Could you come to our institution and do this for an hour? Thinking this will, revolutionize their oncology practice. It won't. I'm very clear I'm not coming because I will fail you. I have found with our 10 hours with our students seems to make a big impact, I think. But I think when I do it with standardized patients, let's see how that really plays out. Because again, we all know, I'm talking about moving lessons from your head to your muscles. That requires practice. And it took me a long time to be a decent improviser. Anyone who's actually tried to perform will let you know that doesn't come easy. So I don't know the answer to that, and that's something I want to help try to understand through research. My impression has been, and like I did that workshop with the neonatology fellows, and the fellowship director and I agreed that 4 hours was enough time to do some real intellectual frame shifting. It felt like people were just having these huge aha moments. Whether it was enough to actually change behavior when they're back in that room, I don't know. I worry that it's not enough. So that's an area for further research. Thank you so much for your time and attention.